don't have to be on there, right?
Good afternoon, everyone. My name is Jenna Webb, and I'll be the moderator for this afternoon's call. We are in the radio room in the Legislative Building in Regina, and with me is Dr. Shahab, Chief Medical Health Officer, and Saskatchewan Health Authority CEO, Scott Livingstone. Today's event will include some opening remarks, then a presentation, and we'll also leave some time for questions. To kick us off, I'll turn things over to Dr. Shahab for opening remarks.
Thank you. So good afternoon, everyone. So first of all, I'll obviously start by expressing my condolences to the families who have lost loved ones, and we are unfortunately reporting 7 deaths today. And this is a reminder of why we need to stay the course till all of us have gotten vaccinated. And then I'll just go over some numbers, and I think at least we can celebrate the fact that we are seeing a plateauing of the cases as far as we can tell over 7-day averages. Our 7-day average of new cases now 230, so definite plateauing. We can probably see that the new measures and the calming effect that all of us are now observing is having looks like some impact on new cases. Our case rate per 100,000 is now 19. Our test positivity rate is 7.8. So still we aren't out of the woods yet, but certainly things are looking positive. But I think it's really important that all of us have been making some minor changes to how we shop, how we go out, obviously not interacting with others outside of our household in our own houses. That's going to be so important over the holidays to, continue doing what we're doing so that we can see, low case numbers throughout the holiday season and look forward to January. Obviously, deaths unfortunately are happening both in the community setting and in long-term care facilities. Hospital and Icu admissions, they are trending a bit down, but, there's a bit of a lag, and people can be in hospital or Icu for days to weeks, so that will continue to be a pressure on the health system, and Mr. Livingstone will be speaking to that. A few other things I just wanted to announce, which are again positive news, is that we're making a change to the mandatory self-isolation period for COVID positive individuals. We're reducing the isolation period from 14 days to 10 days, and that's really important because if you are COVID positive and are isolating, wait for public health to contact you, but generally people who are told to isolate for 14 days now will be asked to isolate for 10 days. And this change is being made on the basis of emerging evidence that shows that, for most people, they are not infectious 10 days after testing positive or start of symptoms. And this allows, people who are COVID positive to return to their daily activities sooner if they're healthy. It obviously applies only to COVID positive cases. People who are notified as close contacts must still isolate for 14 days. So it's important to recognize that previously cases had to isolate 14 days, close contacts 14 days. Now cases will, for the most part, be able to end their isolation after 10 days, but contacts still have to continue for 14 days. And this is because it can take up to 14 days for contacts to become symptomatic. And then if they become a case secondarily, which, about a third of contacts do, then they then will have to isolate for a further 10 days. Also, if you're immune compromised, then it's important for you to wait for public health to see if you can come off isolation at 10 days, or you may require a longer period of isolation, and similarly your clinician, your healthcare provider may also advise a longer period of isolation if you have immunosuppression or if you are in hospital due to COVID or other reasons. And follow the advice of your healthcare provider in that case. The immunization program, as we know, has started, and we know that it will be a slow, steady process over the next few months, and we really won't see a high number of uptake at a population level till spring. So again, it's been a very successful immunization start in Saskatchewan, but we'll have to be patient for the vaccine supplies to come and be given throughout the province over the next few weeks and months. And we absolutely need to do all that we are doing to make sure that our case numbers continue to trend downwards, so that in January we can review what measures need to continue, what measures could potentially be relaxed. And with that, I just want to say that I think this is a week after many weeks that we have positive news to report, and I think we should all be, celebrate and congratulate each other for that. Stay the course and enjoy the holiday season by sticking to our households and connecting virtually with our friends and family. Thank you.
Okay. Thanks, Dr. Shahab. Good afternoon, everyone. Joining us on the line today is Mr. Andrew Will, the Vice President of Infrastructure, Information and Support for the Saskatchewan Health Authority. Andrew is joining us in his capacity as our logistics lead for the vaccine pilot and the rollout. Also joining us is Mr. Derek Miller, the chief of our Emergency Operations Center. I'm going to have Derek provide a presentation in a few minutes of the status of our surge plan, but I do want to start, as Dr. Shahab did, by acknowledging those individuals and families who've lost loved ones over the last 24 hours and share our condolences. Again, this is a sober reminder of the real consequences this virus can have on our loved ones and our community. I'd also like to take the opportunity to thank our healthcare workers across the province. They are the ones that, as we know, are having those tough conversations with families, with loved ones suffering from COVID-19. They're the ones serving long hours in situations where we know we cannot always eliminate every risk that they may come into. And we should be thankful across this province for the work they do each and every day on behalf of everyone in the province. As Dr. Shahab has said, today we start with some good news, something that has been sorely lacking during the pandemic. Today, I'm very pleased to talk about the vaccine pilot that was initiated this week in Regina, and it's going very smoothly. By the end of day yesterday, we had vaccinated almost 250 healthcare workers, and today we're targeting 300 more. In the next few days, we will be expanding the Regina pilot to include key frontline staff in cancer care, the emergency medical services personnel, as well as key staff that are in higher risk areas due to their participation in aerosol-generating medical procedures. Even more exciting is we are expecting to start next phase of vaccination in Saskatoon next week. This first phase of vaccine delivery plan will begin as we vaccinate 1,950 healthcare workers in Saskatoon's ICU, emergency room departments, COVID units, and testing assessment centers where they will receive their initial dose of the vaccine. This is going to occur at a central location at the Merlis Belcher Place Arena at the University of Saskatchewan. In terms of the next step after Saskatoon phase, we're expecting Health Canada approval of the Moderna vaccine soon. This could mean shipments to Saskatchewan in late December. The Moderna vaccine, as you know, can be stored at regular temperature freezer and will make it much easier for us to transport and use in smaller rural locations across the province. And as we start to receive more regular weekly shipments of vaccine, the priority will continue to be on our vulnerable populations and healthcare workers. Widespread vaccine access to begin immunizations of the general population, which is phase 2 of the rollout, is tentatively targeted for April of 2021. The fact that general immunization won't start till sometime after April or during April 2021 underlies the need, as Dr. Shahab has said, for us to continue to take precautions seriously. We must all continue to follow public health orders while the vaccination program is being delivered. It's also critical for the public to know that our system is still severely strained. We will still need help from the people of this province. Given the high case counts, which are leveling off, the large numbers of outbreaks in our hospitals and our care homes, we still require extraordinary efforts just to keep the system from being overwhelmed. This is why I've asked Eric to give us a status update on our surge plans and the continued efforts that we need to keep people safe and save lives. Derek, over to you.
Thank you, Scott, and good afternoon. The SHA's purpose in terms of our COVID-19 pandemic response is to adapt and expand to meet projected COVID-19 patient demand, and then concurrently to be able to deliver essential non-COVID-19 services to patients throughout the pandemic event. Today I'm going to give an update, as Scott mentioned, on our progress to date in responding to the pandemic. I'm going to talk about our offensive and defensive strategies, as well as what we're doing to respond to outbreaks, and then finish off with a review of the status of various service slowdowns that have been pursued. So first item is on our offensive strategy is testing. Obviously a key aspect of containing, mitigating the spread of the virus. Our lab capacity, we have seen occasions where over the past number of weeks we've exceeded 4,600 tests per day, although we have a sustainable lab capacity right now at around 3,400 tests a day. By the end of December, our target is to achieve a daily capacity of 4,000 tests, and this aligned as well with the frontline actual testing capacity across the province at the more than 50 sites that are doing testing right now. We're also pursuing a number of new initiatives to improve our testing capacity with the rollout of point-of-care testing, and which will supplement the lab throughput. As well, we are expanding hours of the drive-through services in Regina and Saskatoon, with expansions in Saskatoon to 7 days a week, and also expanded hours in Regina, and that will be starting in early January. Further, we are improving our public communications to highlight the non-peak time periods for drive-through services to help people reduce wait times and increase overall testing capacity. Another key plank of our offensive strategy is contact tracing. We've seen around 260 cases per day over the last week. We are generally meeting timelines for key steps like positive case notification. However, in other areas like contact notification and the daily monitoring of cases and contacts, we are struggling to meet the demand. We are working to step up capacity, and our key area of shortage is in licensed healthcare professionals, and because of this, we've needed to slow down services in other areas in order to supplement the number of licensed healthcare professionals that are available to support rapid case notification and initial notification of contacts. So we are surging in hundreds of people into support contact tracing, and this is in addition to a number of unlicensed staff that have been provided by the government of Saskatchewan as well as the federal government to do certain aspects of the contact tracing process. We have over 200 people from those organizations supporting the process. Switching to our defensive strategy, so this is really more focused on our hospital response. 2 weeks ago, we established a target to be able to care for 250 COVID-positive patients in our hospitals. Throughout that time, we have created that capacity, although it certainly has stretched our resources. In terms of our ICU surge, our target was 64 COVID-positive patients requiring ICU. We have seen that number, the actual numbers, around 30 cases a day in our ICUs, and we have struggled in our human resource staffing. So while we have beds and space and equipment, ventilators and oxygen for that number, actually bringing in the highly trained staff to do that is a challenge. And I'll just note that how one of the key ways that we're doing this is by slowing down surges, certain services like surgeries, which allows us to reallocate the capacity on surgical units in terms of beds and nursing and other staff, as well as OR staff that can be trained up to support the response in the ICU or on the other COVID units. So the resourcing, as we've said throughout, is a challenge in terms of meeting this COVID demand. Beyond that, I want to touch on our response to outbreaks. So we've experienced over many months outbreaks occurring in a number of different areas, and in response to that, we established basically a pool of people that would be pre-identified and located across the province in order to respond in very quick order to any outbreaks. And this might include outbreaks where there's a surge in care demand. It might be an outbreak where healthcare workers are required to isolate because they're a case or because they're a close contact, and we're able to quickly redeploy resources into that. So to date, we have about 117 staff that have been identified for this type of redeployment purpose, and that doesn't include a number of responses that we've already redeployed staff to, including over 70 people from the SHA that are deployed to support the outbreak in extended care Parkside. We know that this is going to be an area of continued importance and high risk for us going forward. And just to put it in context, if we look at 70 staff just to support one facility in extended care Parkside, and then consider that we have over 150 long-term care homes, 60 hospitals, and literally hundreds of personal care homes across the province, there's a very high likelihood that we're going to be deploying staff in order to supplement the responses in each of those environments. Other specific actions that we're taking in response to the ongoing outbreaks that we're seeing across the province, we have learned over the course of this journey about how we respond, about infection control practices, how to respond quickly, and so on. So we are applying those lessons across other sites. We are in the process now of identifying sites that we would consider at high risk, and we're following up with site inspections to review infection prevention and control measures, as well as safety considerations in those sites. This is in addition to the self-assessments that long-term care sites performed throughout the summer. We are also, in cases where there is an outbreak or where there's a higher risk, we're deploying additional staff, such as infection prevention control and safety staff, to support coaching and training and compliance with the various protocols that can have a major impact on mitigating the risk of outbreaks. We're also in the process of reviewing and identifying some of our older facilities that may have poor ventilation and identifying those for risk mitigation. Typically, that's only a significant factor in cases that have an outbreak with a significant number of cases. We're also looking we're looking forward into the future to plan the vaccine rollout to these sites that have vulnerable residents and patients, and identifying the resources that are needed to support the rollout of immunization campaign. And then lastly, expansion of the point-of-care testing, which allows for more timely turnaround of testing results, deploying those to long-term care and other settings will support early detection and a rapid response to get in front of any potential outbreak situations. Service slowdowns have really been the main lever beyond bringing on external organizations to support and also seeking support through the labor market, which we've been successful in bringing in over 700 additional staff through that. Service slowdowns have been necessary in order to really surge in the resources that we need to actually create the capacity that I've been talking about through this presentation. So since the December 3rd announcement, we have increased about 377 staff towards the surge response, and that's about 64% of the target that was set of 588 resources for potential redeployment. And just for clarification on this, these individuals they're either put into the labor pool and actually picked up and redeployed to support work, or they're basically held in the labor pool and continuing to work in their home location until a need is identified, and then we pull them into the new working environment and department. The selection of service slowdowns is obviously a difficult one to make. We know that any service reduction has a direct impact on patients and residents. We identified over 900 services across the province that we are considering for potential slowdown as part of our overall response. And at this point, we have approval to move forward with about 200 service slowdowns. So it's a significant number, but it's important context to consider that there are over 900 that could be contemplated. Many of these services, the changes that would be involved in a partial reduction in those services, there's really there may not be an obvious impact to patients and clients that are accessing those services, as they would be not necessarily aware unless they had a canceled appointment or delayed appointment or something like that. However, other service changes certainly do have an immediate impact, and we see that most acutely in the surgical slowdowns that are occurring in a number of locations, including Saskatchewan and Regina, where there's been about a 35% reduction in surgeries in those locations, and then also Prince Albert and North Battleford, where they've essentially limited all of their surgeries to urgent, emergent, and cancer only. So again, as I mentioned before, slowing down these services it's essential in order to provide the resources and the capacity to create acute beds as well as ICU capacity in our facilities for COVID patients. Other considerations that are having an impact in terms of service delivery include the introduction of additional safety precautions, which can sometimes cause a service slowdown inadvertently. And a prime example of this is we have introduced new personal protective equipment requirements for aerosol generating procedures in our facilities, and there's a certain amount of time that needs to pass between procedures when you do this, and that reduces the throughput of a unit. We are continuing to consider other potential service slowdowns that might be appropriate in order to respond to ongoing outbreaks, to surge people in to support our offensive strategies like contact tracing and any other areas where we need to supplement resources as part of our COVID response. In terms of key messages, I'll say that safety throughout our response is our number one priority. Safety of our patients, our residents, and all of our healthcare workers is always top of mind as we plan and activate any surge activities. We are committed to, in terms of our slowdowns, to maintain non-COVID services as much as possible. We know the impact that has on patients. Keeping any service disruptions as localized, targeted, and time-limited as possible, and staging those surges and slowdowns to meet the demand. Ultimately, the protection of the healthcare system is in the public's hands, and we need your help. We need your help as we head into this holiday season, especially. Thank you. And I'll turn it back over to Scott.
Thanks, Derek. And just before we go to question, I have some closing remarks, and I'd like to just emphasize some of the things Derek spoke to. So, to date, we've already deployed more than 70 staff to Extendicare Parkside here in Regina. A single long-term care facility, as Derek highlighted. There are 150 long-term care facilities across the province, over 60 hospitals, and hundreds of personal care homes. Even if a fraction of these facilities experienced a similar challenge like Parkside, we would have to deploy hundreds of staff, potentially thousands, depending upon what response was required. That's why it's critical for us to have these service slowdowns as part of our surge activation toolkit. There are many other reasons why we need it as well, but one of them is because we can't turn our services around on a dime. We can't meet contact tracing and testing volumes without extraordinary efforts. And we cannot deliver some of the added measures that we're working on to save lives, one of them being the new point-of-care testing options in long-term care. Also, our vaccine delivery program. Both of these will require extra staff. They will not get done without extra resources. And while our staff are making every single effort to keep these slowdowns as localized, time-limited, and targeted as possible, this is still an essential part of the surge plan. It's still necessary for us to save lives and protect our healthcare workers. So I want to end by challenging the people of Saskatchewan this Christmas. We know that there are many out there who are vulnerable citizens at risk for getting COVID-19, and we know that there's lives on the line. So please, when you think about what you have to give up this Christmas, think of it as a gift for someone who will get to experience a next Christmas because you've helped save their life. Thank you.
Thanks, Scott. We'll move to questions and answers. I've got a few in the room with me and some on the line as well. For those in the room, just make sure that you project so the folks on the line can hear the question as well. We've got a question in the room.
Yeah, I suppose to the SHA, can you provide the latest information we have of the situation at Extended Care Parkside in terms of how many folks are sick and how many residents unfortunately passed away?
Okay. So currently, and this would be as of yesterday at 4 o'clock, so there are a total of 138 residents, 78 remain positive, 57 have recovered, and there are 82 positive staff at the facility.
And in terms of how many residents there have passed away?
There's 20 deaths today. So,
What, at this point, what went wrong at Extended Care Parkside to see an outbreak this severe?
well, I think it's not a single thing. I think to say what's wrong, we believe we have experienced one. It is the single biggest outbreak in long-term care. The virus has shown a very high infection rate, and we think there was multiple components to that. And I think you've already seen through our response some of the things that are highlighted that needed to be put in place to support care at that. So that's infection control practices. Up to the SHA standard, the additional PPE, staffing levels within the facility because of some of the things that were going on during the outbreak wasn't normal. And then looking at just the structure of the facility, the number of 4-bed patient rooms, which is not conducive to slowing down the spread of a virus as aggressive as COVID-19.
Let's go to a question on the phones, please.
We have Zach Visera with the Star Phoenix.
Hi there. This one for Scott and potentially also for Derek. One thing that was mentioned in this surge plan update is that many healthcare staff at this point are required to self-isolate because they themselves have been exposed to COVID-19, and we've been looking at that number that gets reported every day. Scott, I'm wondering if you can say how many healthcare workers are self-isolating right now and what impact this is having on your operations and your ability to respond.
So I'll see if Derek has that number. I don't have the number today, Zach, but we can get that for you. But I will comment on the second part of the question and then turn it over to Derek for the first if he knows the number. So I think as Derek has outlined, one of the single biggest challenges we're facing is the number of staff that are being taken out of service because they're either COVID positive or have been exposed and are a close contact. And this has been a significant impact, and it's contributed to slowdowns in services across the province, but it also contributes to our challenge of providing support where outbreaks are occurring because of the expectation for the SHA to come in and help support staffing in other types of facilities that we would not normally do so. Extended Care is a good example, but there are other examples across the province where that has been a challenge. And really the widespread community-based transmission is where we're seeing the virus come into our facilities, but it has a very dramatic effect. And just to give another specific example, so we had the number of staff redeployed to Parkside. Those are staff that can't be used someplace else. But we have a unit in Saskatoon where the outbreak has been declared, and even though the staff are self-isolating, we don't admit it to a unit where there's an outbreak, so we have vacancies. Half that unit has beds, empty beds that we can't admit to. So it's not just the staff being off, Zach, it's the implications of having these outbreaks in acute care facilities and the implications there are for patient care.
Derek, is there anything you'd like to add?
Derek, do you know that number?
I don't have that number. We'd have to get back to them.
Okay.
Sorry.
Yeah, we'll get back to you on that, Zach. Is there a follow-up question?
Yes, I think there's another question I'd like to ask, maybe generally to both Mr. Livingstone and Dr. Shahab. I know that modeling done, I think, at the end of November, early December, had us potentially at a potential high of 562 cases, I think, sometime in mid-month. And very thankfully, that has not happened. I noticed that both of you stressed that we are not out of the woods yet, and even though our case numbers have plateaued, it's not time to drop the guard. I'm wondering if you can help explain maybe why we didn't see that dramatically high case number and why this is not a reason to get too comfortable.
So, do you want to start, or do you want me to start?
I can speak.
Okay, go ahead.
Yeah, thanks. That's a really excellent point. And as I said, we, on a weekly basis, we look at the modeling, and we just had a discussion yesterday with the modeling team, and we look at the epidemiology. You know, we have weekly summaries that sometimes I bring and present, as I did on Monday. The good news actually is based on the fact that we are all, complying with the orders, with the recommendations. And when we analyze cases of the last week, for example, what we see is ongoing transmission within households, so secondary cases within households. And, we all try very hard to prevent that. If people live in crowded situations, they are offered accommodations to isolate outside of the household. But we do see the bulk of the transmission happening, secondary cases in the household. We are still seeing transmission in, obviously you shouldn't really have anyone outside of your household in your house, but we are seeing, transmission in workplaces. And that's, again, not really when you're at work for the most part. It's during break. It's when you're kind of interacting after work, for example. And that's why, we have to practice what we're doing right now, for example, masks, physical distancing, hand hygiene, and staying home if you're sick. And I think that's going to be crucial. We are not seeing, so why we think the curve is plateauing, obviously we're not seeing some of the large numbers of outbreaks we were seeing before in sports teams. So again, in the future we'll have to think, how can play start again once the case numbers come down? What can we learn from the outbreaks which can restart play in a safer way? So sports have been slowed down, restaurants, bars, the reopen guidelines have been revised, more distance for group activities, spin classes, more distance for restaurants, 4 at a table, 3 meters apart. All of that is having incremental impacts. We are not seeing the same rate of outbreaks in those settings. And I think all of that is contributing. But ultimately, the actions we take on a day-to-day basis is what counts. And so with that, Scott, do you have any?
Well, and the only thing I'd add, Zach, is just to remind, we've said all along with respect to the modeling is it's not a crystal ball. It's really what we plan to, and from the very start with the offensive and defensive strategies for the SHA, we focused on ensuring that we are as prepared as we can be for that almost worst case scenario. And then just to reiterate what Dr. Shahab has said, it is a positive thing seeing the daily case numbers level off, but we are seeing numbers still at a high level that could potentially overwhelm the healthcare system, because 250 cases a day and 5 contacts per case, and an effective reproductive number that's over 1, and a high test positivity rate are all metrics that are not moving. They're moving in the right direction because they're getting lower, but they're not where we're comfortable with respect to backing off our surge plans, particularly when we're seeing those other types of outbreaks that are really drawing on the system.
We have a question in the room.
In terms of the vaccination plan, is there any thought to vaccinating the homeless population ahead of the widespread vaccination, or First Nation communities? Is the SHA working on plans for any of that?
I can start. Yep. So thanks. So, as we know, there's the national recommendations about, sequencing or prioritization. And we already know that, Pfizer has been approved. It's coming in specific amounts week by week, very measured amounts. And then hopefully we will have the Moderna vaccine also coming. Hopefully we're expecting some positive news over the next few days to weeks. And we really do have to start where the risk is highest, residents of long-term care facilities, personal care homes, and staff who work in areas where there are COVID patients. So that has to be the first priority. And then after that, obviously, we will be looking at age groups, in 5-year decrements. And then as vaccine supplies pick up, January, February, March, obviously we'll be looking at other priority populations. So there's a committee that's looking at that actively. But a lot of that will have to wait till our supplies pick up. So once we've done the initial, cohort, long-term care residents, personal care home residents and staff, and frontline healthcare providers working in COVID areas, then we will have to look at other populations.
Follow up?
Yes. Mr. Livingstone, we spoke with the union representing correctional workers, and they say they've contacted your office about mass COVID testing at correctional facilities. With the number of outbreaks that we've seen over the last little bit, is that in the future, is that a plan that is going to be happening?
So I'll have Derek and answer after I add to my answer, but before he gets into the specifics about that request in correctional facilities, I think it's important to understand that throughout the pandemic, we've been working with partner organizations, and I know Dr. Shahab has as well, with respect to proper use of PPE, the proper cleaning procedures in any communal living setting or correctional facility. And with respect to testing, there is some work going on right now with corrections, similar to what's happening in long-term care around and point-of-care testing. But I do want to remind folks that, it's a good opportunity for me to remind folks one is we're not using our testing capacity today, and it's there. And although prisoners can't walk out of a correctional center and get tested, the staff can. And since July 14th, we've had broad-scale testing for symptomatic and asymptomatic testing in this province, and we're not using that testing capacity each and every day. And so staff in correctional facilities have always had the opportunity, just like teachers and school-aged children or any other member of the public since July 14, to be tested as many times as they choose to be. But Derek, can you add to some of the conversations that are occurring around point-of-care testing with the corrections folks?
Yeah, thanks, Scott. So just further to the initial response, when there are outbreaks in the corrections environment, our medical health officer and public health teams, they definitely respond and they establish a testing regime for the staff and the inmates through mobile testing in most cases. So you're asking more specifically about more surveillance type testing. And potentially using point-of-care testing equipment as a way of doing that. That is something that we're currently having discussions with corrections about. Of course, there's a resource requirement and training and other considerations that need to be established in order to introduce that type of surveillance approach into a corrections environment that would need to be worked out. So we are definitely examining that.
We'll go to a question on the phone, please.
We have Lisa Schick with CJME.
Hi. Now, healthcare workers will be getting those first injections in Saskatchewan when you start the first phase, but long-term care residents are also in the first phase. Just wondering when they're going to start seeing vaccines rolling out to those long-term care facilities.
Andrew, want to speak?
Yeah. And Andrew, do you want to take that one?
Yeah, I'm happy to speak to that. Right now, we're in the process of doing our initial pilot, and as you've indicated, staff that are at risk of exposure of COVID have been the initial pilot priority. There's some reasons for that. One being the Pfizer vaccine. The requirement of the pilot is that it be delivered specifically to an acute facility and that not be moved off of that location. We do expect that other vaccines, such as Moderna, will be more mobile and reach those populations better than the current restrictions that are on the Pfizer product. There is also the potential that that the restrictions with the Pfizer vaccine could change over time, and that may give us more flexibility. Right now, our priority is really to test our processes in terms of
booking people for appointments, providing the vaccinations, and documentation into the health record. As we move from the pilot in Regina to Saskatoon, it will be a chance for us to really test our processes for replicating to different teams of staff that will be providing the vaccination in different communities. And then we'll be able to take those learnings and use those to reach other high-risk groups. But certainly long-term care residents and staff working in long-term care facilities are a top priority group to reach.
Is there a follow-up, Lisa?
Yes. So it seems like the first phase starting next week is the timeline moving up a little bit. What does that mean for the full timeline? Are we expecting to get these doses of vaccines a little quicker, maybe move to the second phase a little quicker?
Andrew, do you want to take that, or do you want me to?
I'm happy to answer that. So right now, what we've been able to confirm is, of course, we've received the initial doses for the pilot in Regina. We have confirmation that we will receive the second dose for those people that received the 1,950 in the pilot in Regina, and we will also be receiving next week the vaccines for both the first and second dose of the 1,950 that will be provided in Saskatoon. We haven't at this time received further confirmation of other shipments, but we are expecting that will be coming soon.
Any other questions in the room?
This is for Scott. I've heard that the COVID unit in Regina was moved from the 6th to the 5th floor. Does the SHA have any comment on that, why that wasn't done? And I know there was an outbreak listed there maybe last week or a week and a half ago.
I don't know. Derek, do you know, is EOC aware of that move?
Sorry, I couldn't quite hear. I heard Regina movement of COVID. Sorry, could you repeat the question? Or
I've heard that the COVID unit in Regina, the general, moved from the 6th to the 5th floor, and I'm wondering why that may be. And
yeah, I can provide some information on that. So our COVID response in our hospitals is based on a stepped approach where we create a COVID unit or part of a unit or a pod, and then as we get more and more demand, we expand into other spaces, and we prepare those spaces in advance so we can move into them. And the sequencing and units were identified as part of the surge planning in the spring. What we found since that time is more information about how COVID patients are treated clinically, which has had an impact on the oxygen supply necessary for those COVID patients. And so while we did plan for oxygen requirement increases in ICUs at tertiary and regional hospitals across the province and have done a lot of upgrades to be able to meet potential capacity, we didn't address that same, same requirement on medical or other units based on what we understood at that point in time was going to be the clinical requirements to treat those patients. So this was a slight adjustment in terms of the unit. They basically moved them from the unit which didn't necessarily have the level of oxygen that we felt comfortable with and moved them to another unit. And it's a slight adjustment in the plan, and otherwise we'll continue along that stepped increase with the follow-on units that would become COVID units if required.
Is there a follow-up, Adam?
do either of you think there should be an inquiry into what happened at Parkside? There's some calls for that publicly right now.
Do you want me to start? Yep. So we understand that the opposition called for an independent inquiry, and we don't get to make that decision, but certainly, as part of the SHA, we do a whole, critical incident reviews, program reviews. We've had a team inside the Parkside Extended Care looking at the multiple factors that could have been involved with respect to the aggressive spread of the virus in that facility. As Derek had already pointed out, we've also identified some of those facilities across the province where we have potentially higher risk, either because of the layout of the facility. For example, they have multi-bed rooms, like for residents per room, or they're an older facility where there may be ventilation, or where we have seen potential breakdowns or challenges with respect to the use of infection control practices. So with respect to a review, if a review does occur, we know that Extended Care certainly weighed in with respect to, specifically around the building itself, but we would, if a review occurred, we would like to see it look at both our relationships with long-term care providers that are outside of the auspices of the SHA, how programs are operated within those facilities as it relates to standards that are created by the SHA, and our day-to-day relationships. As you know, with Extended Care, we put in a new agreement so that the SHA could take over operational control of the facility so that we actually could support it in the way in which those residents and staff needed it to be supported.
I'll take another question on the phone lines, please.
We have Peter Lazinski with the PA Herald.
Hi, this is a question for Mr. Livingstone. We saw in the documents released today and hearing about the system that there's significant pressures in the north right now. We heard from someone a few weeks ago who said his wife was in for a non-COVID related lung treatment and was concerned to find, and at least alleged, that there were on the same floor as a COVID patient, and there was some sharing of staff. What sort of have the pressures on the health system resulted in, I guess, less ability to cohort staff in the facilities?
Well, I'll start that question answer, and then I'm going to ask Derek to follow up with a little bit. But just, I can't speak to the specifics of the case, but I will say that as part of the plan for providing care for COVID patients in hospitals across the province, since day one, since March, there is a designation of facilities and triggers for folks. So it would not be unusual to see a COVID patient on a ward with non-COVID patients if it was a single patient, with respect to how staff would care for those patients. Now, certainly with respect to the proper use of PPE, hand washing, and all those other types of environmental controls we would put in place to ensure that the infection didn't spread and the person would be in a single room. And again, there's a trigger point where that unit would become COVID only, and Derek can speak to that, but it's not uncommon. With respect to the cohorting of staff, particularly in rural and northern areas where we have integrated facilities, has been a bigger challenge than where there's specific facilities for either long-term care or acute care, and we have granted exemptions for facilities and put extra precautions for infection control and the use of staff that we can't cohort in a smaller facility, because if we cohorted the staff to long-term care, we wouldn't have anybody to care for patients in the acute care, and vice versa. So that's always been part of the plan. I could see how that would be concerning for a patient to know that there was a COVID patient on their ward, but there are infection control protocols. Our COVID-19 patient pathway deals with those issues, and we've been doing that all along throughout the pandemic. But I just asked Derek if he had anything to add.
Thanks, Scott. I'll just mention in terms of caring for a COVID patient in an environment where it might be just be one patient on a unit, it might be just one resident that's COVID positive in the long-term care. Our health system is very well practiced and educated, and with training and various protocols in order to manage patients that have any kind of disease that could be transmitted within an environment. And so those practices are the same practices that we're using now. Obviously, with it in a pandemic environment, we've scaled it up in terms of our response plan and so on. But on a unit basis, the staff are well equipped to be able to handle a single patient that's COVID positive. The other point I'll just make is that the cohorting staff in long-term care, it is part of the public health order, and there's a process that we need to go through to receive exemption for anybody to work in more than one long-term care. And Scott gave an example of cases where that might happen. and there are a few occupations where they are provided an exemption. But again, in those cases, they are following all of the infection prevention and control and other environmental and administrative controls that we put in place in order to mitigate any potential risk of spread of the virus.
Is there follow-up?
Yeah, we heard from the Ministry of Social Services this week that they've been setting up some temporary facilities for kids in care to be able to properly self-isolate when there isn't space. Is that strictly limited to, I guess, kids in care environment, or is there also intention to look at something like that for issues where there's not appropriate space in long-term care?
So I'll turn it over to Derek, but I would just highlight that throughout our pandemic response, and there's a number of examples that Derek could give, having appropriate self-isolation sites for those who live in settings that is not something that's readily available to them has been part of the pandemic response. We have worked with other agencies, not just social services, but the Saskatchewan Safety. Yes, the Public Safety Association to actually help provide those types of services, and other community-based partners. But Derek, you can follow up, because I know it's broader than just kids, and it goes across the province in a number of different instances.
Yeah, we are supporting the Ministry of Social Services in the provision of assisted self-isolation sites at locations across the province. They are run and operated by the Ministry of Social Services, typically in a hotel environment, and the SHA provides health services support to them in those various locations. I'm not familiar with in terms of the kids specific case that you're mentioning, but broadly speaking, we are providing support to those operations across the province.
That is our last question, so I think we'll close things off for today. Thank you.